Hello and welcome to today's webinar. It's jointly sponsored by AAIDD and HRS Incorporated. The title of today's webinar is Disparities, Perceptions, and Misconceptions, Putting People Before Their Diagnoses. I'm your presenter today. My name is Craig Escude. I am a board-certified fellow of the American Academy of Family Physicians, a fellow of the American Academy of Developmental Medicine. I've practiced for more than 20 years in the field of healthcare for people with intellectual and developmental disabilities, providing healthcare for people with complex medical conditions and mental illnesses, as well as severe and profound levels of disabilities. I was the medical director of Hudspeth Regional Center in Whitfield, Mississippi, up until 2018. While I was there, I founded a program called the DETECT program, which its primary function was to provide education, training, and consultations to practicing healthcare providers in community settings to help improve their ability to provide healthcare for people with intellectual and developmental disabilities. And currently, I am the president of Health Risk Screening Incorporated. We're going to jump right into a few difficult topics, and that is, talking about disparities in people with disabilities versus people without disabilities. And this chart here shows the average age of death in both females and males and people with and without intellectual disabilities. And when we look at this chart, it shows that females with intellectual disabilities die about 19 years earlier than than females without disabilities. Males with disabilities die about 16 years earlier than people without disabilities. One reason for this could be because of the lack of preventative care. We know that women with intellectual disabilities are less likely than women without them to have had cervical and breast cancer screenings, or really even to have ever visited a gynecologist. Individuals with IDD are less likely than people without IDD to have visited a dentist regularly, to get eye and hearing tests, and also to receive timely vaccines. When we look at what the CDC says about health disparities in people with disabilities, they talk about how many people with disabilities live with complex health conditions. We know that some people with disabilities have significant other medical conditions or medical conditions that can be complex to treat. They have limited access to quality health care and health promotion programs. They may not participate or miss cancer screenings, as we mentioned. They can have poorly managed chronic conditions, such as epilepsy and other conditions. They're more likely to have obesity, to have undetected poor vision, and also to have mental health problems, and certainly to use psychotropic medications. We know a lot about polypharmacy and the overuse of psychotropic medications, and that's a whole other topic of discussion. There was a study done in North Carolina looking at health disparities among adults with developmental disabilities. They looked at about 1,600 people with disabilities and about 4,400 or so people without disabilities. And the conclusions showed that people with disabilities were more likely to have a diagnosis of diabetes, high blood pressure, cardiovascular disease, and chronic pain. They were more likely not to have had their teeth cleaned in the past 5 years, or never to have had their teeth cleaned at all. They were more likely to lack adequate emotional support. 24% of the adults reportedly had no one to talk to about personal things and often felt lonely. They were more likely to have had no exercise in the previous month. They were less likely to have had a diagnosis of arthritis, which I find quite interesting. And what I can gather from that is that I think clinicians aren't necessarily thinking about it. Maybe people have a difficulty communicating that they're hurting, that their joints are hurting. And so again, people often do communicate in different ways, and it may be through behaviors. And because of a lack of understanding, healthcare providers may just think, well, they're just doing this because they have a disability. And there were also significant disparities in breast and cervical cancer screening, as well as in oral health care, which we mentioned before as well. We know that there are health disparities. When we're talking about perceptions and misperceptions, those are out there as well too. There are misperceptions that an intellectual or developmental disability in and of itself is a disease. That people with IDD don't need health screening because they're not going to live that long or live as long. That people with IDD cannot lead a productive or fulfilling life. That challenging behavior is, well, just because they have a disability. That's why they act this way. That people with IDD can't comprehend things, can't understand things, and that people with IDD can't communicate. These are definitely misperceptions that are out there. I know I've seen a lot of these, and I'm certain that many of you have as well too. You know, not so long ago, many people with disabilities were placed in institutions, were put in institutions, and they weren't really seen in the best light. And I would certainly agree with you if you said that that continued as well. Even though things have improved, there's still a ways to go. But over the past few years, few decades, people with disabilities have been moving more so into community settings. And with that, they're relying on community clinicians for their health care. But what's interesting is that most physicians, nurses, dentists, physical occupational therapists, nurse practitioners, most healthcare providers have received very little training or have had very little experience in providing healthcare for people with intellectual and developmental disabilities. And speaking from personal experience, I certainly was one of those. When I started in the field, I had essentially no training, no understanding, no experience in how to provide healthcare for people with disabilities. And what I learned from the nurses who had been working at the center where I started working. They had been working there for years, and I learned a tremendous amount from the nurses, as well as the direct support professionals and other people who had been working there for years. And that traditionally has been how people have learned about the healthcare needs of people with disabilities. And again, that's something that needs to change. But when we look at this, what's the result of this? That people are in communities and they're going to community healthcare providers. What's happening now is that people with intellectual and developmental disabilities are looking to healthcare providers who have very little understanding of their healthcare needs, or even who they are as people first. These misperceptions that not only healthcare providers have, but many of us, many people have, is that they will have reduced opportunities for inclusion in general, that there might be lower consideration of preventative health care, lower consideration for life-saving measures, earlier referral to hospice care, and earlier recommendations for do not resuscitate status. And I'll tell you a little story about hospice referrals. I had sent a patient to a hospital for pneumonia. She had an aspiration episode and developed significant pneumonia. And I had shortly gone out of town, came back a few days later. And when I got back, the staff told me that the patient had been put on hospice care. So I called the admitting physician and just kind of asked about what was going on and the pneumonia. And she basically said that, well, yeah, the pneumonia had cleared up, but she wasn't eating. So we put her on hospice. And I thought, I had a few thoughts, but I had a couple of questions, and I said, so, all right, she's doing fine pneumonia-wise. She's breathing on room air, not requiring oxygen, not requiring any specific treatments, but she's just not eating. Is that correct? And he's like, yep, that's what's going on. I said, well, why don't we take her back to the center, let her come back home with us, and see how she does, and we'll go from there. And they said, okay, and they discharged her back to us. And as soon as she got back to her regular environment with people that she knew, she began eating again and did just fine. So again, not understanding the differences can lead to earlier referrals for things like hospice, as well as do not resuscitate orders as well. And when we look at these misperceptions and misconceptions leading to decisions that aren't necessarily the best, we can see, looking at what's been going on with this pandemic, the Department of Health and Human Services has received complaints from advocates in at least 4 states about policies that talk about excluding people from life-saving measures like ventilators, that put people with cognitive disabilities on a lower tier for receiving higher levels of care that can be life-saving. And fortunately, the HHS Office of Civil Rights responded by saying, hey, the ADA is not waived during this pandemic, and that persons with disabilities should not be denied medical care on the basis of stereotypes, assessments of quality of life, or judgments about a person's relative worth based on the presence or absence of disabilities. I've said a lot about healthcare providers not having an understanding, but that's not true for all of them. And I am a member of the American Academy of Developmental Medicine and Dentistry, and we put out a policy statement on ventilators and COVID-19 in April of 2020, saying that we're resolved that the presence of an intellectual or developmental disability must not be used as an exclusion criterion for ventilator support or the allocation of other scarce medical resources. This includes, transplants, organ transplants, or intensive care beds, or ventilators, as we said. These decisions should not be made based on the sole fact that a person has a disability. There may be appropriate times. There may be certain situations where hospice is appropriate, just like it is for anyone else, or that a DNR order is appropriate, just like for anyone else. But we need to make sure that these decisions are not being made solely because the person has an intellectual disability. So those are some kind of difficult things to talk about and some negative things to talk about, but we're going to talk about how can we combat these negative stereotypes. And one thing that would be helpful in general is that there would be more research in the field. I think that's very important to research more about healthcare needs, healthcare issues, and treatments in people with disabilities, for sure. Another big step would be to improve education, in particular to healthcare providers, but also to people who support people with disabilities, as well as the general public, to educate people about people with disabilities. Healthcare providers in particular, educating healthcare providers is probably the primary passion of mine in this field, and it comes from my own personal experience of having known very little in the beginning. Very, very humbling to have a very little understanding of how to treat people when you've been trained and spent years in school to do that. So I want to provide education to healthcare providers. And in fact, one of the things that we've done in health risk screening is to create an e-learn program called the Curriculum in IDD Healthcare, which is geared to healthcare providers, that they can participate in a 6-module course and get the fundamentals, the basics that are needed to be able to provide healthcare for people with disabilities. But the last thing here that you see in blue is what we're going to focus on And it's things that we all can do, that you can do, that you and I can do to help people with intellectual and developmental disabilities to be seen as a person first. Um, and so how can we change some of these perceptions or some of these misperceptions? What can we do on a regular basis? I always like to, we present problems, but we need to try to present solutions and helpful tips as well. And that's what I try to do. So here are some things that can help that can help change these misperceptions. And so when we're talking to other people about people with disabilities or introducing them to others, we want to lead off with who the person is rather than their diagnoses. We want to introduce them to others with respect and importance. We want to describe their quality of life positively. We want to ask about screening during healthcare visits. I mentioned earlier how there's a lack of screening or a lower level of screening for cancers and other things. So we can get in the habit of asking healthcare providers about screenings, and also to speak to the person with the disability and encourage others to do the same, not just about them. And so we're going to go through each of these and talk about some examples. So we'll start off with leading off with who the person is rather than their diagnosis. And so these are a couple of things, couple of ways to do that. So you could say something like, this is Mike. He's an avid watcher of sports. In fact, you should see him cheer when someone hits a home run. His favorite team is the Cubs, but doctor, lately his vision seems to be causing him some difficulty. You start with that, and it tells that physician in just a few seconds that this is a person with likes and dislikes. And he may even share some of those same likes and dislikes with the healthcare providers and others. And that he has a problem that's causing him, some trouble. And we want to see if we can get that addressed. Or the second example, this is Franny. She made the scarf she has on today, and she is a quite talented painter as well. Lately, we noticed that she's having more trouble holding the paintbrush. She seems to become agitated when she grabs it, and that's how she often shows that she's in pain. She becomes agitated. We're here to see what can be done to get her back to painting again, something that she loves. So again, talking about that person and who they are before talking about their diagnoses, their disabilities, and other conditions that they may have. We want to always use person first language. I know most of you out there know what it is, but not everybody does. And the more we use it, the better example we're setting for other people to use it as well. And person first language is very simply putting the person before their disability. And the chart you see here has examples of person first language and things that you should avoid saying. So a person with a disability rather than the disabled or the handicapped, or down on the list, a person who uses a wheelchair versus they're confined to a wheelchair or they're wheelchair bound. Again, talk about the person first. So this is a good chart that you can use to help others understand this better. The second thing on the list about changing perceptions. When we're introducing people to others, including healthcare providers, we want to introduce them with respect and importance. And so here are a few examples of how we can do that. So we can say, this is John. He's the opinion leader in our home. That says a lot. He's the person who leads the opinion. He's the person that other people listen to. He's important. How about this one? This is Judy. She prefers managing the meal preparation at home, but she's here for her checkup today. So it's saying, hey, at home, Judy usually takes care of meals and that's what she likes to do. And so she had to take off of that today to come here for her checkup. Or, hey, this is Tom. He took off from his job at Sam's Club today for his appointment. So you're talking about who Tom is, that he has a job, and he had to take off to come to this appointment, that he has importance and that he has value to others. Or even something as simple as this last one. Samantha told me she's not fond of having to come to the doctor. I guess she's just like the most of us in that respect. You know, Samantha's just like the rest of us. She's just like everybody else. None of us really like to come to the doctor, and she's expressed that to me too. So it's a way to communicate importance, or at least some sense of equality in the value that every person has. So these are things again that we can all do as we talk to others about people that we support. So let's look at the third one. Describe their quality of life positively. Um, that's really, really important and really helpful to do. A couple of examples. This is John. His favorite activities are baseball and basketball. You should see him hit the ball. He's active. He likes sports. He plays sports. Again, John has a quality of life. He enjoys things. The next one, when Susan goes to church, she's having a harder time going up the steps. So Susan goes to church. She interacts with her community. You can add to that. Susan loves the choir music when she goes. You know, and letting them know that they're a member of society. Uh, you know, Tim, he makes the best sandwiches. You know, next time we should probably bring you one. Um, Again, letting them know that they do things that other people like, that other people enjoy, and maybe we should bring you one that he makes next time. Helps people to see people with disabilities as people first. Sharon's friends at work mentioned that she seems to be having a harder time seeing. Well, this tells us that Sharon, first of all, works, and second, that she has friends at work, and her friends noticed that there's a difference in what she's doing. Again, it shows that this person has a quality of life, that they're valued by other people. And that is very important. One of the things I stress when I speak to clinicians specifically is that a different quality of life does not equal a lesser or a lower quality of life. It's very important to understand. Um, I recall an incident. You know, on this next slide, I'm going to also talk about end of life decision making, and that how a DNR order should never be made simply because a person has an intellectual or developmental disability. And I recall a time where I was referring let me unfortunately say that this happened more than once, not just one time. But I was referring someone to an emergency room who had a significant health issue going on, and I described to them who they were and gave them their diagnoses. And when I mentioned, you know, significant intellectual disability, the first question from that physician's mouth was, "Well, are they a DNR?" Which is a do not resuscitate, where no life-saving measures are given in the event that someone's heart stops beating or they can't breathe on their own. And I said, no, they're not. And his next question was, well, why not? And I said, because this person normally has a functioning quality, a nice quality of life, enjoys life, has activities, friends that he interacts with on a regular basis, and we don't make decisions about DNR simply because a person has an intellectual disability. So the more we can show that and teach people that, the more they will see people as people, and showing people that they have others, that they have a quality of life, and that they're valued by other people, can go a long way to preventing this negative type of stereotype that we see. And it's not all clinicians. I know that there are some great clinicians out there. I know that for a fact. But there are also a lot that could benefit from looking at things in a little bit different light. So again, going back to screening, as we talked about before, one of the things that we can do is just ask about screening during a healthcare visit. Will it help us, or maybe it will help remind the clinician that this is an important thing to do? So, you know, we might say things like, hey, is it about time for her mammogram? Or when was the last time his cholesterol was checked? Do you remember what it was? Or Do you have any diet recommendations to help him stay healthy as he gets older? Again, lets them know, hey, he's getting older, he wants to stay healthy and active. What's the best thing for us to do here? Or what age should he have a PSA test for prostate cancer? So if we think about these things during a healthcare visit, we can remind clinicians to think about these things as well too. I always like to say that when we're looking at aging and health screening in people with disabilities, that we should utilize the same preventative screening recommendations that are used for people without disabilities. In some cases, like in Down syndrome or Fragile X, there may be other conditions that need to be screened for as well. But at a minimum, people should use the same screening recommendations for everyone. That's what we're looking for, the same for everyone, whether they have a disability or not. So the last one here, speak to the person and encourage others to do the same. And if we want people to speak to the person with a disability, we need to model that behavior as well. But we can redirect the conversation. If a healthcare provider or someone else is not speaking to that person, you might say something like, that's a good question. Let's ask Jack, see what he has to say about it. Or something like, I don't know, Doc. Let's see what Mary thinks about your recommendation. Or why don't we ask Denise if she thinks she'd be able to sit still for that eye exam? And just kind of redirect that conversation back to that person. Help them to realize that this is a person here who has thoughts, who can comprehend, who has value, and can interact and indicate to you, maybe in a different way, but can indicate to you likes, dislikes, preferences, and can make decisions and choices to the best of each person's ability. So, what we've been talking about is communicating value and communicating human traits. And we can't always be there. Maybe sometimes we have to send someone to a different level of care. Maybe we have to send them to an emergency room, or we have to send them to a hospital or to a doctor's office, and we're not the ones that can go with them to help, show that person in the best light, to help present them as a person first. But there's a document that can help us to do that. And that document is called the Health Passport. There are a number of different versions of health passports out there. You may have your own that you've created, and that's certainly great if you do. But in general, a health passport is really a summary of health information, which again is important. It has basic demographic information, but then has the diagnoses and the medications and the past surgical history. It can help a clinician in particular. They can look at these things on a couple of pages and say, all right, I've got a good medical picture of this person, without having to go through maybe a very large chart to get a general picture. But then it also includes a lot of very helpful information that helps a healthcare provider or someone else or another type of supporter to see that person, as an individual with likes and dislikes, who can communicate, but maybe just communicates differently, who may become agitated at times, but there are things that can be done, and maybe they're not agitated just because they have a disability. So let's take a look at some components of a health passport. Health risk screening has a health risk screening My Health Passport document. This is available free. It's on our website. It's actually on our COVID-19 page right now. It's a downloadable form that is a PDF. You can fill it out and save it for each person that you support. If you do use the health risk screening tool, this is now a component that we just recently released that is built into the health risk screening tool for each person. It's in their record. There's a tab that says Health Passport. You can complete it, your information saved. You can print it out anytime that you need to use it. So, the basic components include demographic information, such as name, address, all that kind of good stuff, who their healthcare providers are, their primary physician, their psychiatrist, their dentist, their preferred hospital, So again, basic just information that we all need to have available. Contact information, emergency contacts as well. Some clinical summary type information, such as their diagnoses, their medications, their allergies, whether it be medication allergies or food allergies. And I will encourage you that if someone does have a medication allergy, to please also talk about the type of reaction, because that can be very, very helpful in making clinical decisions to know what type of reaction someone had to a particular medicine or to a food. And then this is so important. How does a person express themselves when they have pain? Because we know people do it in all different ways. And for instance, in this example, it says that they may pinch or pull at their ear, even if the pain is not in their ear. And that can be super helpful for a healthcare provider to know. And maybe they'll walk in a room and the person's pulling at their ear, and all they can think of is, well, one of two things: either, well, they do this just because they have a disability, or their ear's hurting, and well, I looked at their ear and there's nothing wrong with it. But if they know that it could be a sign of pain somewhere else in their body, then they may continue to look and address that person's pain, or at least give them some medication for it. So again, this type of information is so unbelievably helpful. Looking at the next one, usual manner or level of mobility. This is helpful in a couple of ways. Okay, first, so we know how a person typically gets around, but it also can help let us know when the person gets back to their baseline. The same thing with diet and assistance with eating and drinking. If we know that a person normally can feed themselves and normally uses, say, maybe a cane only for long distances or something like that, then we know that that's their baseline. And if they're in the hospital and they aren't able to pick up a spoon, um, but they know that the person normally feeds themselves, they may be less likely to say, oh, well, he's just not eating because he can't feed himself. Or they may not try to rehabilitate a person back to the level of walking with a cane if they think, well, that person they just probably always just sit in a wheelchair, so we're not going to worry about getting physical therapy involved or anything like that. So again, it's very helpful for clinicians to have this information to understand when a person returns back to their baseline where they might be ready for discharge. Other things on a health passport, weight is really important, and in weight over the previous few months is so valuable, because if you see a trend that the weight has been going down, especially, that can be very helpful in making clinical decisions. How does a person take their medicine the best? Some people don't take pills well, but they will take them just fine if they're crushed up and put in a little applesauce. So again, very helpful and important information to know. We all know about bowel patterns and how important that is. There's information that you should put on there as well. How about communication? How does the person communicate? Maybe they use words, maybe they can point to things. Maybe if they had a picture card, it would be really, really helpful. Maybe they have a communication device. Whatever it is, having this information on this document can help people understand the best ways to communicate with other people. And when we get to social information and we look at things like, hey, my friends and people who know me describe me as, and this is the place to put some personal information, some quality of life information, some information about what the person likes and does and what people like about them. And the more details and information you can put in there in this section, the more people will see that person as a person. What do they like? How do they express themselves when they like things? What do they dislike? In this example, they dislike thunderstorms and having anyone try to undress me. And that is really helpful information, especially in a healthcare setting, because, if they know this up front, you can address things differently. You can handle things differently. How best to communicate with me? What's the best thing to do? Maybe if you sit down with me and look at me directly, I'll understand things better. Sleep patterns, favorite activities. How do I interact with people that know me, like friends? And how do I interact with people that don't know me? Again, it can be very helpful. When I'm angry, what do I do? So let's say I pull my hair when I'm angry. again, instead of someone saying, "Oh, he's doing that just because he has a disability," they may say, "Hey, that's what this paper says that he does when he's angry. So we need to look at that. Maybe he's angry about something, or maybe he's in pain. So let's assess that. When I'm upset, how do you help me calm down? What's the best thing to do? What will help me calm down better? What are some things that I'm sensitive to?" So yeah, I'm sensitive to blow my nose on a paper towel, and that's actually my son's very sensitive to that, and he doesn't have a disability. It's just he hates blowing his nose on a paper towel. So that would be really helpful to know, to not do that. Things that help you pass the time again also can be helpful. And if you do use the health risk screening tool, there's information. The healthcare passport, the health passport that's built into the tool will automatically include the health risk screening tool scores, which can be very helpful to clinicians pointing out areas of higher risk in people with disabilities. But you can also attach it, or if you don't use the tool, you can just leave that part blank, or you can reach out to us and we'll show you how you can use the tool. So in summary, we know that health disparities do indeed exist, but improvements are being made in this area. People with disabilities are living longer. We know that, and it is in part through better health care and through more screening that is being done. I mean, it wasn't maybe 30 years ago that people with Down syndrome had a life expectancy of about 25 years. And now the life expectancy is 60 plus years. And that's because they're receiving better care and better support. There are misconceptions about quality of life and the valuation of people's lives. And if there weren't, we wouldn't have had these issues with COVID-19 and worries about rationing healthcare to people with disabilities. These do exist. They still exist. But point number 3, the federal government, advocates and organizations and others are actively speaking out and teaching about equal consideration for life-saving measures. And there are a couple of laws behind that as well too that we need to remind people about. But really, the take-home thing I'd like you to really think about from this talk here is that there are things that we can do, that you can do, that I can do, that you can teach others to do, that can help change these misperceptions about people with disabilities. So I'm going to leave you today with a call to action. I want you to continue, because I know you're already doing this, but continue and increase your efforts to help people with IDD to be seen as people first. I really want to thank you for taking the time to take part in this webinar. I want to thank AAIDD for joining with us with health risk screening to partner in partnership to bring you this webinar. If you liked what you heard, you will have access to recordings. They will be on the AAIDD website as well as the HRS website. You can visit our website to sign up for our newsletter, also to download the health passport. Again, it's available to you. There are several other things you may be interested in as well while you're there. The handouts that you saw and some of the slides is from the book Clinical Pearls in IDD Healthcare. That is a book that we put out as well. I authored the book with the idea of providing healthcare providers and supporters of people with disabilities with some clear, concise information about various healthcare issues. And I certainly wish good health and wellness to all of you. And again, I really thank you for joining us today. And I also thank you for doing what you do each day. Many people who work in this field don't get recognized or thanked enough. So thank you for what you do very much. And feel free to reach out to me at HRSonline, hrstonline.com as well.